Welcome to another episode from the Veterinary Medicine Digest. Today we are conducting a rigorous clinical deep dive into a fascinating and complex presentation involving a 10-year-old male neutered Labrador retriever who suffered from acute non-ambulatory tetraparesis. This specific case serves as a masterclass in navigating the diagnostic challenges of paraneoplastic syndromes, particularly when they are secondary to an ectopic insulinoma, a rare and secretive malignancy that does not always reveal itself within the confines of the pancreatic parenchyma. To understand the gravity of such a case, we must first establish the physiological foundation of glucose homeostasis and the devastating consequences that arise when the regulatory mechanisms of the body are hijacked by neoplastic transformation. In a healthy canine patient, blood glucose is maintained within a very narrow physiological range, typically between 3.3 and 6.2 millimoles per liter, or 60 to 111 milligrams per deciliter. This balance is the result of an elegant dance between the glucose-lowering hormone insulin and several counter-regulatory or diabetogenic hormones, including glucagon, cortisol, epinephrine, and growth hormone. Within the islets of Langerhans, the beta cells act as the primary sensors and regulators. When blood glucose concentrations rise above a threshold of approximately 100 to 110 milligrams per deciliter, these beta cells respond by rapidly increasing the rate of insulin secretion. Conversely, when glucose falls below 60 milligrams per deciliter, insulin synthesis and secretion should naturally cease to allow the counter-regulatory mechanisms to restore euglycemia. However, in the presence of an insulinoma, these beta cells become unhinged from their normal feedback loops. These functional tumors retain the ability to produce and secrete insulin independently of the blood glucose concentration, leading to repetitive and potentially life-threatening periods of hypoglycemia. Hypoglycemia itself is a diagnostic dilemma because its manifestations can be vague and nonspecific. While clinical pathologic hypoglycemia is defined by a blood glucose level of less than 3.3 millimoles per liter, clinical signs often do not manifest until the concentration drops below 2.2 to 2.8 millimoles per liter. The symptoms are largely attributable to neuroglycopenia, which is a state of cerebral hypoglycemia. The brain is particularly vulnerable because it has a high and continuous requirement for glucose as its predominant energy substrate, yet it lacks the capacity to generate or store it in the form of glycogen. When neuronal glucose concentrations diminish, adenosine triphosphate production fails, leading to vascular permeability, edema, and eventually neuronal death from anoxia. This can manifest as altered mentation, seizures, ataxia, and weakness. Furthermore, the activation of the sympathetic nervous system as a compensatory response can cause muscle fasciculations, behavioral changes, and tremors. In our Labrador retriever case, the owner reported a 2-week history of gradual hind limb weakness that progressed into acute tetraparesis over 4 days, accompanied by hyperexia, lethargy, and unusual behaviors like excessive blinking and facial twitching. Before we can definitively diagnose an insulinoma, we must consider the broad list of differential diagnoses for hypoglycemia in dogs. These can be categorized into several groups, including physiological causes like extreme exercise in hunting dogs, or pathological processes such as sepsis, severe hepatic disease, and other extrapancreatic tumors. Hepatic dysfunction is a major player because the liver is responsible for glycogenolysis and gluconeogenesis, which are essential for maintaining blood glucose in the post-absorptive state. Similarly, hypoadrenocorticism, or Addison's disease, results in a deficiency of cortisol, which is a critical counter-regulatory hormone that stimulates gluconeogenesis and maintains peripheral insulin sensitivity. In the case of our Labrador, initial investigations ruled out many of these possibilities. The patient's electrolytes and basal cortisol were normal, effectively excluding hypoadrenocorticism, and other biochemistry values were unremarkable except for the profound hypoglycemia. The blood glucose was measured at 1.1 millimoles per liter on biochemistry, and high insulin levels of 41 microunits per milliliter were documented simultaneously. This combination of low glucose and inappropriately high insulin is the hallmark of an insulinoma. The neurological presentation of this Labrador was particularly striking and leads us into the discussion of paraneoplastic polyneuropathy. While the central nervous system signs of hypoglycemia are well documented, the peripheral nervous system can also be affected by insulinomas through paraneoplastic mechanisms. Insulinomas are recognized as the most frequent cause of paraneoplastic polyneuropathy in dogs. The neurological examination of our patient revealed that he was non-ambulatory and tetraparadic, with absent paw placement and hopping in the pelvic limbs, delayed proprioception in the thoracic limbs, and reduced segmental spinal reflexes. Specifically, the patellar reflexes were absent bilaterally, and the withdrawal reflexes were very weak in all four limbs. This indicated a generalized neuromuscular disease localizing to the lower motor neurons. The pathophysiology of this polyneuropathy remains a subject of intense academic debate. Some researchers suggest it is caused by glucose-mediated metabolic disturbances in the neurons, while others favor an immune-mediated mechanism where the immune system attacks nervous tissue antigens that are similar to the antigens found on the tumor cells. Another theory posits that the tumor may release neurotoxic substances that lead to axonal degeneration. Interestingly, there is often no distinct correlation between the severity or duration of the hypoglycemia and the occurrence of the polyneuropathy, suggesting that the tumor itself is the driver of the nerve damage rather than just the low sugar. To further characterize the neurological deficits in the Labrador, electromyography was performed. The results showed marked spontaneous electrical activity, including fibrillation potentials and positive sharp waves in the pelvic limbs, and mild spontaneous activity in the thoracic limbs. These findings are classic indicators of muscle denervation and strongly favored a polyneuropathy or myopathy over a junctionopathy like myasthenia gravis. This aligns with other historical reports where electrophysiological findings in dogs with insulinoma-related polyneuropathy showed axonopathy. Once the clinical suspicion of an insulinoma is high, the search for the tumor begins. This is often the most challenging part of the process because these tumors are frequently very small, sometimes only millimeters in diameter. Abdominal ultrasonography is a common starting point, but its sensitivity is reported to be quite variable, ranging from 28 to 75%. Computed tomography is generally considered a more sensitive modality, especially when contrast-enhanced computed tomography angiography is utilized. In a study of 14 primary insulinomas, computed tomography correctly identified 10, whereas ultrasonography only found 5. In the case of our Labrador retriever, the imaging findings were highly unusual and diagnostic of an ectopic location. Computed tomography revealed a mesenteric mass near the ileocecal junction, along with enlarged lymph nodes and multifocal target lesions on the liver. Critically, there were no obvious masses present in the pancreas itself. Most insulomas are found within the pancreatic parenchyma, with roughly 44% in the left lobe, 35% in the right lobe, and 14% in the body. Ectopic insulinomas are exceptionally rare in the literature, making this mesenteric presentation near the ileocecal junction a significant clinical finding. The mass showed marked contrast enhancement in the arterial phase, which is characteristic of the highly vascular nature of neuroendocrine carcinomas. During surgery, an abdominal exploration confirmed a 2 by 3 centimeter well-encapsulated mass at the mesenteric aspect of the ileocecal junction that was not invading the surrounding organs. The surgeons also found an adjacent 1 centimeter mass, suspected to be a lymph node, and multifocal white nodules on the liver. Biopsies of all these structures were taken for histopathology. The histopathological evaluation was definitive. The primary mass and the adjacent lymph node were described as effaced lymph nodes containing metastatic carcinoma of neuroendocrine origin. The liver nodules also confirmed metastatic neuroendocrine carcinoma. The high mitotic count of 48 per 2.37 square millimeters indicated a highly aggressive malignancy. In the context of the clinical picture of hypoglycemia and hyperinsulinemia, these findings were consistent with a metastatic insulinoma. This staging would classify the dog as having World Health Organization Stage 3 disease, which denotes distant metastasis. Traditionally, Stage 3 insulinomas carry a significantly shorter survival time compared to Stage 1 cases, where the tumor is localized to the pancreas. A retrospective study of 116 cases found that the presence of metastases was the only other variable besides treatment modality that was significantly associated with a shorter overall survival. Specifically, dogs with Stage 2 or 3 disease were approximately 1.5 to 2-fold more likely to die, regardless of whether they were treated surgically or medically. Management of these patients requires a multimodal approach. Immediately upon presentation, our Labrador received a dextrose bolus, followed by a constant rate infusion of 2.5% glucose to maintain euglycemia. It is important to note that rapid infusions of high-concentration dextrose can sometimes be counterproductive in insulinoma patients, as the sudden rise in glucose can stimulate the tumor cells to release even more insulin, causing a vicious cycle of hyperglycemia and rebound hypoglycemia. After surgery, the dog's glucose stabilized fairly quickly, allowing the weaning of glucose supplementation. However, the management of the paraneoplastic polyneuropathy required ongoing intervention. Suspecting that the tetraparesis was driven by an immune-mediated or inflammatory paraneoplastic process, the clinical team started the dog on dexamethasone, which was later transitioned to a tapering course of oral prednisolone. Glucocorticoids are a staple in the management of insulinomas, not only for their anti-inflammatory effects in neuropathy, but also because they stimulate hepatic gluconeogenesis and interfere with the affinity of cellular insulin receptors for glucose, thereby helping to maintain blood sugar levels. One of the most exciting aspects of this case in contemporary insulinoma management is the use of tyrosine kinase inhibitors like Toceranib phosphate. Toceranib phosphate is a multi-receptor tyrosine kinase inhibitor that was originally approved for the treatment of mast cell tumors, but it has shown increasing promise in the management of neuroendocrine tumors. It acts on important growth factor receptors, including the vascular endothelial growth factor receptor and the platelet-derived growth factor receptor. In humans, a similar drug called sunitinib has been proven effective for advanced pancreatic neuroendocrine tumors, increasing progression-free survival and tumor response rates. In canine medicine, growing evidence suggests that Toceranib can provide long-term glycemic control and slow disease progression, even in metastatic cases. A retrospective study comparing dogs with recurrent or metastatic insulinomas found that those receiving Toceranib had a significantly longer median overall survival time of 399 days, compared to only 67 days for the control group receiving only palliative care. Our Labrador retriever was started on Toceranib phosphate at a dose of 2.75 milligrams per kilogram every second day starting 4 weeks after surgery. The outcome for this patient was remarkably positive given the aggressive nature of his disease. 1 week after discharge, he remained non-ambulatory, but had improved strength and had regained his appetite. By 3 weeks post-operation, he was able to stand with harness assistance, and by 4 weeks, he was ambulatory without assistance. This rapid neurological recovery post-surgery highlights the favorable prognosis of paraneoplastic polyneuropathy when the underlying neoplasia is successfully addressed. By 83 days after the operation, the patient was recovering well and showed no signs of hypoglycemia. At 190 days, he was capable of longer walks and independent stair navigation, and by 292 days, he was still alive with normal blood glucose readings. This case demonstrates that even with distant metastasis to the liver and lymph nodes, aggressive surgical debulking followed by targeted medical therapy can lead to excellent quality of life and significant survival times. To contextualize this success, we should look back at the broader statistics of canine insulinoma survival. Historically, surgical treatment has always been superior to medical management alone. A large retrospective study reported median survival times of 20 months for dogs undergoing surgery compared to only 8 months for those treated medically. Dogs treated surgically are 2 times more likely to survive 1 year and 6-fold more likely to survive 2 years compared to those receiving only medical intervention. The Labrador's journey from a state of total flaccid paralysis to full ambulation is a powerful reminder of the potential for recovery in paraneoplastic cases. While the pathophysiology of the nerve damage is not fully understood, the clinical response to removing the primary tumor burden and administering steroids strongly supports the theory of a reversible, likely immune-mediated process. It also underscores the importance of a multidisciplinary approach involving emergency critical care, neurology, surgery, and oncology to manage the diverse manifestations of the disease. As we conclude this journal club discussion, there are several critical learning points to take away from this unique Labrador case. First, insulinoma should always be at the top of the differential list for any dog presenting with hypoglycemia and generalized neuromuscular symptoms, particularly if they are medium to large breed and middle-aged to older. Second, the absence of a pancreatic mass on initial imaging does not rule out an insulinoma, as ectopic locations can occur within the abdominal cavity, necessitating thorough exploration and the use of advanced techniques like computed tomography and angiography. Third, paraneoplastic polyneuropathy can mimic many primary neuromuscular disorders, but its clinical resolution is often tied to the management of the underlying malignancy. Finally, the advent of tyrosine kinase inhibitors like Toceranib phosphate offers a new and effective tool for extending the survival and improving the glycemic control of dogs with advanced metastatic or recurrent beta cell neoplasia. This case serves as an inspiring example of how modern veterinary medicine can provide a second chance at a high-quality life for patients facing even the most daunting oncological and neurological challenges. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.